to present today at this really important inaugural conference. As a radiation oncologist, I meet patients every day who are facing a tumour diagnosis, and it's obviously a very scary, anxiety-provoking time. But despite that, patients trust me, and for that I'm very, very grateful. They trust in my experience and my training. They trust that I'll make the right decision at the right time, engage people, others when it's needed. So for that, I'm truly humbled, and it's truly a personal honour for me to be here today. So when Nick and Kimberly reached out and said, would you be kind enough to give a presentation today? I said, yes, absolutely. So it's a real pleasure to be here today. I love what the CEO of the foundation described today. It really opened my eyes to what this foundation is capable of. When I had looked online about the foundation, there wasn't really, a quarter of what he presented. So what this foundation has been able to achieve is amazing, not just from a research perspective and advocacy perspective, but also on a personal level. You guys remind us about what's important, what matters to you guys day to day, and that puts things into context for us. So as a clinician, I thank you for that, and I greatly appreciate it. So I'm from Adelaide, and I work mostly at the Royal Adelaide. I also work at the Australian Bragg Centre. So this was touted to be the first proton therapy facility in the Southern Hemisphere. It's been a long journey, and I'm happy to say that the journey has not finished. We're still going. Okay, so despite the headlines, despite what you hear amongst the rumour mill, we're still here, and we're still fighting the good fight. So with your help, we hope that we'll be able to achieve what we really need in this country, and that is a proton therapy facility that's able to give treatment to patients in this region. So I've got no disclosures. So I've been asked to give a talk about the role of radiation in the management of chordoma. Many of you who've had this diagnosis no doubt have had discussions about surgery, discussions about radiation, and maybe even drugs as well. Radiation therapy is meant to be involved in the care of at least 50% of patients with a cancer diagnosis. And in Australia, we do nearly hit that mark, which is great. And that's, I think, because of the system that we have here. Other countries don't enjoy the same type of system. In chordoma, though, radiation is really important in the control of the disease. So radiation is not going to make the cancer go away. It's not going to make the cancer disappear from your scan. But what we can achieve is control of the disease. So if you've had an operation to remove the tumour, by having radiation, we hope that the cancer won't come back. If you can't have an operation, by having radiation, we hope that the cancer won't grow. That's the role of radiation in the local disease setting. The other role of radiation is in the management of symptoms. So disease, depending on where it is, depending on what it's growing next to or invading, can cause symptoms. And that can be pain, it can be bleeding, it can be breathing issues. And radiation definitely plays a role in that situation as well. So I'll be talking today about how we achieve this and what the options are for Australian patients. So in broad terms, radiation can be divided into conventional radiation and particle therapy. They're both forms of radiation. It's just that conventional is available here in this country, whereas particle therapy is not. And conventional radiotherapy can involve different techniques. It can involve intensity modulated radiotherapy or VMATs, volumetric modulated arc therapy. It can involve stereotactic approaches as well. Whereas particle therapy is a catch-all term for proton beam therapy and other ions as well, such as carbon. So let's focus on conventional radiotherapy, because this is what we've got available here in Australia. Because every capital city, most towns have access to linear accelerators, we have rapid access to VMAT techniques. My vision's not very good.
The other side.
Oh.
Yeah. Oh, yeah. Okay. I'll have my back towards you guys. And obviously, because we have this technology readily available here in this country, there is a significant cost advantage as well. You know, a course of radiation treatment is about 12K in terms of Medicare, terms. And so it's a cost-effective way of delivering treatment in a rapid fashion. You know, we don't have to go applying to the federal government for funding, which can take weeks and weeks. We don't have to arrange for treatment to be carried out overseas. We don't have to ask patients to jump on a plane. So this is, I guess, the advantage of having this treatment here in this country. And typically for chordoma, we're talking about very long courses of radiation. Okay? So to deliver 70 gray plus, we're talking about probably somewhere in the order of 6, 7, maybe even 8 weeks of radiation therapy. And if you can have that in your own town, if you can have that in your own city, then the impulse on you and your family is significantly reduced. But this technique has its limitations. Unfortunately, chordoma happens in really tricky to treat places. And so if you have a tumour that's up against a critical organ such as the brainstem, such as the sacral nerves, such as the optic chiasm, then we are going to be severely limited in terms of how that radiation is being delivered in the most effective way, because we have competing issues. The other type of conventional radiation that we can deliver is the shorter courses of treatment, and that might be for metastatic disease. So where the tumour has started, let's say in the clivus, but then it has spread to the lungs, and it's causing local problems, we can offer shorter courses of radiation, where the goal is to improve quality of life by reducing the symptom burden. Okay. So these are the general concepts when it comes to conventional radiotherapy using VMAT techniques. The group in Canada published this paper where they were talking about using VMAT for local disease only. Canada is another country, another first world country that does not have proton therapy. So they've also had this same issue, perhaps not to the same degree because patients just have to go across the border for proton beam therapy. But they've also investigated the role of conventional radiation therapy for local disease. And by using 70 gray plus, they found they had a reported 5-year local control rate of 65%. So that's okay, but it's not as good as for proton therapy. And of course, as we mentioned before, there's always that balancing act. How much treatment can you get in to cause the tumour to be controlled versus what is this treatment going to do in terms of the side effects and the complications of the treatment? It's always a balancing act. And this is what we have to deal with on a day-to-day basis as radiation oncologists, trying to balance the competing issues all the time. The other option is to have stereotactic radiotherapy, and normal conventional linear accelerators, which are widely available in Australia, are capable of delivering stereotactic approaches. We also have a number of other unique platforms available in Australia, such as CyberKnife and gamma knife. So all three platforms, linear accelerators, gamma knife, slider knife, can all deliver stereotactic radiation therapy. And this technique might be suitable for smaller targets and perhaps inoperable tumours. The goal here is to deliver radiation over a very short period of time. So unlike VMAT, where patients are coming every day for many, many weeks, stereotactic approaches would mean patients would only come for a few sessions, maybe even only one, where a very high dose of radiation is delivered to a very small target. And this is an example of a patient who's had slider knife treatment for a very small clival chordoma. Okay. If I saw a clival chordoma of that size, I would be absolutely delighted, because that's not what I normally see. Chordomas that I encounter in my clinic are generally much, much bigger. But this one, wow, if I saw that, I'd be chopping at the bit. But look at that. So we've got the picture of the face on the left, top left, and we've got all these little blue lines coming out of the face. And that's because the cyberknife machine is a small accelerator mounted on a robotic arm, and each of those lines represents a field of radiation, and it's coming at the tumour from an infinite number of angles, the view of delivering a very high dose of radiation to that very small target. Now, Josh mentioned the consensus guidelines that were published before. So this is coming up to about 10 years old now, this consensus guideline. And I'm really excited that these guidelines are being updated later this year. So I'm really looking forward to seeing what the community of clinicians who are involved in this disease day to day are recommending. I won't go through every single one of these points, but the point I'm trying to make from this is that experience matters. Okay. A radiation oncologist needs to be aware of the nuances of chordoma. They need to be aware of the technicalities and their limitations, because unlike a lot of diseases where you see the target and that's it, for chordoma, it's nuanced. You have to have multiple targets, and you have to be able to deliver a certain amount of radiation to each of these targets. And the goal, as described in this guideline, is to deliver at least 74 Bragg. Okay. So 74 Bragg. Remember the previous slide? 70 Bragg was what we could achieve really with conventional. But 74 is the minimum, and that is because chordoma, unfortunately, is a highly radiation-resistant tumour. Okay, and compared to other diseases where you might try and get 60 Bragg, and that's generally enough. You have to get 74 Bragg, and if it's right up against an organ such as the brainstem, which has a limit of 54 Bragg. That's a 20 Bragg differential over 1 or 2 millimeters. How do you achieve that with conventional? It's just not possible. So this is where protons can be advantageous. So particle therapy, let's talk about that. We don't have this in this country, but it is available in many others. Particle therapy can mean protons, can mean carbon, and there are two groups that would benefit the most from this technology. The first group is the group where you're aiming to reduce the late effects of your treatment. And typically, we're talking about younger patients, kids, teenagers, young adults with cancer who are going to hopefully survive for many, many years. But if they do survive for many, many years, they're going to realise the impact of our treatment. So let's try and reduce that impact as much as possible by giving the best technology we we have available. The other group is where we're trying to escalate the radiation dose, and this is where chordoma lands. Okay. Of course, there are young patients with chordoma as well. So, like I said before, some cancers we only need to get 60 grade. Lung cancer, gliomas, that's the recommended standard approach. But for the standard approach for chordoma, we're talking about 74 grade. And this is an example of what can be achieved with protons. So on the left, we've got the conventional radiation plan, okay, treating a pliable chordoma. And then we've got on the right the proton plan. Okay. So all of these pretty colours represent a certain amount of radiation. Okay. And as you can see, for the VMAT plan, there's a large spray of radiation that goes to the other organs. This includes the rest of the brain, the eyes, the optic chiasm. Whereas with the proton plan, we're sparing a lot of these structures, and that's where the advantage lies. But not only that, you can see here that this is the brainstem here, okay? And because we're trying to spare the brainstem, because if we cause brainstem necrosis, that can mean end of life. The coverage of the target is actually compromised just in this zone here. Whereas on the proton plan, we're actually covering the target more readily, okay? But he's still being able to spare the brainstem. So I hope that explains diagrammatically why we think protons should be available. So are there any questions? I'll keep listening. And there have been studies to try and quantify these benefits. So this is a study that was carried out by a group in America. This is in the setting of head and neck cancer. And what they did was they were able to calculate the doses for each of the organs using VMAT, which is the second column, and then with proton, which is the third column. Okay. And what they found was that the doses to the parotid gland, the major salivary gland, is significantly reduced using protons. And the same goes for the hard palate and for the oral cavity. Okay, these are all statistically significant. But what did that actually mean for the patients? Well, they also correlated this to side effects that were reported by the patients. And they found that by using proton therapy, we could reduce pain through the oral cavity, we could reduce the rates of dry mouth, and we could improve the general function of the patients as well. Okay. So I think the evidence is there. And then this group here in the States studied the outcomes of chordoma patients receiving proton therapy. They evaluated 100 consecutive patients, all of whom received a median dose of 74 gray, as we said before. And the 3-year overall survival rate was 83%. I'd love to see longer term data, because 3 years is not quite enough in my book. I'd love to see what the 5 and 10 year outcomes are, but maybe that's for the next publication. So this is a map of the world showing where all the proton and particle therapy facilities are positioned. It's pretty damning, right? They're all north of the equator. There's 128 centres that are operating worldwide. None where we live. And there's 42 centres in construction. One of those centres in construction is in Adelaide, but there's been a stay in the works, as you've probably all heard. We'll come to that later, I'm sure. So what about in the setting of recurrent chordoma? So recurrence can mean it's grown back where it started, in the clivus or in the sacrum, or it can mean spread to other parts of the body. And whenever we're faced with this situation, we have to take a multidisciplinary approach. We have to have a panel where we discuss what all the various options are. We have to have surgeons, radiation oncologists, medical oncologists in the room where we review all the tests, all the results, and come up with a recommendation. Okay. So if we're talking about widely spread disease, okay, we could use a palliative approach where we're focusing the treatment on symptom control. If the spread is in just 1, 2, or 3 areas, then maybe we can take a metastasis-directed approach. And that could be a more aggressive form of radiation, where we're targeting these spots with a high dose with the aim of controlling the growth of those spots. So in local recurrence, hydrotherapy should be considered. And there are strong advocates in the world of radiation oncology who suggest that heavy ions such as carbon ion should be considered. And the reason why people think this is it still has that sharp radiation dose fall off that protons have, but they're associated with a higher biological effectiveness as well. This carbon ion therapy is less affected by hypoxia, low oxygenation levels. These tumours are typically low in oxygen because there's been a lot of disruption to the local blood supply, either because of the way the tumour grows, or because of prior surgery or prior radiation. But this technology, carbon ion therapy, is even less available than proton beam therapy. So there are a number of centres in Japan. For some reason, the Japanese go mad for it. But there are also centres in Germany, Austria, and Italy. None in the US, surprisingly. So proton centres have popped up like mushrooms in the States, but none have carbon ion capability. And that is because of the massive cost of these facilities. So we're talking about 5x compared to a PBT facility. And that's because the accelerators that are required to bring the heavy ions to the required energy are so much larger. Toxicity still exists with carbons, but maybe at a reduced rate. Okay? And the goal, of course, is to try and minimise those toxicities that I've listed there. So how do Australians access treatment overseas? Has anyone here gone overseas for protons?
Yeah.
Okay. So about half a dozen. And were you all able to access the medical treatment overseas program? Did anyone self-fund? Okay. So what was the financial cost of going overseas for treatment?
The top program only offered for my wife and daughter. Obviously, our other daughter was self-on card as well. So, yeah.
So this was in 2017. US dollars, it was $350,000 US for 40 rounds at Boston Energy College.
Yeah, it's a great recommendation for me.
Yeah, Hien too.
It's funny how the world works, eh?
Yeah.
That's a really common story that we've just described. But what about the emotional cost? Does anyone want to say anything about that? Yeah? Don't have to, but look, it's a massive journey, right? So whenever I meet someone with this diagnosis and we're considering chordoma, you know, I spent a long time talking about what the journey is going to look like, because as a patient and the family, at the very initial step, I gather not much is really known. You know, it's this abyss of whatever. And my explanation is there's a number of steps that we have to go through with MTOP in order to get the outcome that we want. But the outcome may not be what we want. So there's always that uncertainty. And then there's the uncertainty of the timeline. So these timelines that we're talking about might take 6, 8 weeks. And not everyone has that luxury. And so that's a massive emotional burden, I think, for families and the patients. Like, how do I take this punt? It's going to take 8 weeks for me to know what the outcome is going to be, and I might not be happy with the outcome. And if the outcome's not what I want, am I prepared to go and self-fund or go through some sort of GoFundMe sort of situation? Are you prepared to put yourself out there and let everyone know, let the whole public know your situation? It's a massive thing, right? And I think that's part of what I have to do in terms of counselling and trying to work out what the best way forward for each person is. And some patients will listen to that and they'll say, not for me. I'm just going to go to what's available here in Australia because it's more certain, because it's more rapid, because I can get it done in my own time. So these are some really tricky conversations that we have to have, and it's not easy, that's for sure. So we have this program called the Medical Treatment Overseas Program. It's a federally funded program, and there's hoops to jump through, there's hurdles to get across. One of those is the need for comparative planning. So the federal government, in their assessment, they need to have objective data that proton therapy is more advantageous than what we've got available here. And so, as part of what we do at the Bragg Centre in Adelaide, we receive referrals from all over the country, sometimes even New Zealand and other places, where we are tasked with producing a photon plan, a conventional one, or a proton plan, and a proton plan that we compare it to. And so, in doing that, we hope to provide the reviewers in the federal government some objective way of making a decision whether or not proton therapy is the right way to go. And yeah, it can take 6 weeks, 6 to 8 weeks, for an outcome to be made. Now, the federal government last year, they reviewed the need for comparative planning, and they've taken out the requirement for comparative planning for 4 different situations, of which skull-based chordoma and chondrosarcoma, following maximum safe resection in patients aged up to 25 years, do not need a comp plan. Okay, so we felt that was probably a step in the right direction. Okay, we would maybe have liked it to have been loosened up a bit more, but was it seen to, the comp plan was seen to be a bit of a barrier in terms of timelines and getting patients across for the treatment that they actually need. And when we reviewed our comp planning data, what we learned was that of all the comparative plans that are referred to us, remember we also get referrals for other diseases as well, not just chordoma. 38 of those referrals were for chordoma since March of 2022. And about a fifth of those, that makes up about a fifth of our work. Of the 38 cases that were referred to us, 13 were sent to MTOP, And 10 of those cases were successful in receiving funding by the federal government at a cost of 300k, 250k US. We don't know whether 17 had a referral to MTOP, but as you can see here, not everyone went to MTOP. Some patients actually went for more surgery, and some patients elected to have conventional radiotherapy in their home state. I've met patients who don't have a passport, and they don't want to get a passport. And a patient says to me, no, don't worry about it, I just have to treat me here because that's what I want. And we respect that. Even though we know deep in our heart that proton beam therapy would be better. And as you can see here, over the years, the number of proton therapy applications that were approved under MTOP have steadily increased year on year. So it's heading in the right direction. I think part of that is because there is more awareness. Groups like you guys are making others more aware of MTOP, making others more aware of proton beam therapy, so we're getting more referrals, and more of those referrals are going to MTOP. So that's a great thing. And the government will look at these numbers and they go, oh, okay, all right, we've got a problem here in this country. Let's do something about it, because the numbers aren't going down, they're going up. And if we're talking about 36 patients in a 12-month period going overseas at a rate of 350k, the numbers actually end up stacking up, right? And remember, these proton therapy facilities, the lifespan of these machines is about 20 years. So 20 years, I think you can do the maths, and it turns out to be cost effective. Yes, we receive applications from all over the country. Some are from regional and remote areas, and the average age for Chordoma referrals is 43. We've had patients from the age of 3 all the way up to the age of 80 being referred. And when we issue these reports, this is what we use. So the proton plan on the left, the conventional photon plan on the right, and then the differential dose between the photon and the proton plan in the top right there. And this is what we do for all of our cases. Now, a colleague of mine, Kelly, will be up next, and she'll be talking about the registry, but I just wanted to highlight that we are doing research in this area. We're tracking the outcomes of patients who would be eligible for proton therapy, because we need to be able to demonstrate how effective protons could be. Okay, but I'll leave that for Kelly to outline for you guys later. And I thought I'd just touch on ongoing clinical research. So I can't do as good a job as Josh, but certainly there is a lot of, there is some work in this area, and most of it is in the combination of therapies. Can we combine radiation with other treatment modalities such as immunotherapy? We know that Chordoma is chemo-resistant, so chemo is not going to work. Chemo is ineffective for this, but can we use the immune system by activating the immune system with radiation, coupling that with immune therapy to improve the outcomes of our patients? And basically, there are two mechanisms in which this could occur. So focused radiation would mean lower radiation doses to the bone marrow being the factory that produces the cells in the immune system. So if we can maintain the immune system at the required level, then maybe we can have more effective immune therapy. Okay. We can also make tumour cells more susceptible to immune therapy, because some of these cancer cells can be really clever. They can, put on a Harry Potter invisible cloak and make themselves invisible to the immune system. But maybe the radiation treatment will get rid of that cloak and make them more susceptible to immune therapy. These are the theories. And this study was opened. It's not recruiting at the moment. I wonder if that's because they're just, they've met their recruitment target maybe, I'm not sure. Basically what they're doing is they're combining nivolumab with stereotactic radiosurgery in the setting of patients who've had their chordoma come back. And this study was funded. It was funded by the foundation with a $300K US grant. So I'm really looking forward to seeing the outcome of that. And when I looked at this, I thought, well, is there a possibility we could do something with proton therapy? Could we combine proton therapy with immune therapy and try and make the treatments work synergistically and more effectively? Because the barriers is that we don't have protons in Australia. We lack research funding, and the research funding cycle is so competitive in this country. And you know, this is a rare disease, so unfortunately for rare disease, the focus for cancer research is generally on the breast cancers and the prostate cancers and the lung cancers. But that doesn't mean that we shouldn't try, and I really think that groups like the Foundation can make a difference by advocating for this particular disease. So let's continue to work together, let's lobby, and hopefully we can improve the situation for our patients. I just wanted to highlight that I'm just one of many faces at the Bragg Centre. This is the team, and we do some great work, but we hope to continue that work. So I hope you guys can support us in that effort. To the Foundation, thank you so much for inviting me. It's been great, and I'm happy to take some questions.